Good evening to all. Today, you are engaged with the second session of our special webinar series, Insight into COVID-19, organized by the Society of Medical Laboratory Sciences, University of Peradeniya, to scientifically explore and understand the COVID-19 pandemic. As you all know, the coronavirus directly affects to our immune system, and it's necessary to develop our immunity against this COVID-19. Therefore, vaccination is the main way to control this pandemic. For that, the World Health Organization has recommended different types of vaccines such as Pfizer, Mrna, Covishield, Sinopharm to prevent symptomatic, often severe illness. In Sri Lanka also, the government successfully conducts vaccine campaigns throughout the country, but somehow people refuse to take these vaccines due to unnecessary fear for the side effects, or maybe due to comparing between these vaccines. Therefore, it's really important to conduct awareness programs about the importance of taking vaccines and to clear the misunderstanding among the people. So today, we have invited Dr. Champa and Ratnatunga as the guest speaker of our program. So on the behalf of our society, we warmly welcome our guest speaker, Dr. Champa and Ratnatunga, and the senior lecturer, Dr. Charita Mendis, and all the participants to this program. From now on, you can engage with the session. Over the next few hours, you will be able to gain more knowledge about how the immunity developed against COVID-19, what are the available vaccines, how vaccines work against COVID-19, efficiency of vaccines against COVID variants, side effects of vaccines, cautions and contraindications, and finally, the importance of getting vaccinated and clearing misconceptions.
Now, I would like to introduce our guest speaker, Dr. Champa and Ratnatunga. She is a senior lecturer in microbiology and immunology at the Department of Microbiology, Faculty of Medicine, University of Peradeniya. She holds MBBS, MSc in Biostat, MPhil in microbiology from Sri Lanka, PhD in immunology from Australia. And also, she is currently working on immune response to COVID-19 vaccines in healthy and immune-compromised populations. So, I cordially invite Dr. Champa and Ratnatunga to continue the session. And also, I would like to remind you that if you have any questions, you can definitely clear that at the end. So for now, please kindly mute your mic.
Hello, everyone. I'd like to thank the organizer. I'm Dr. Champa. I'd like to thank the organizers for inviting me. It's very kind of you to ask me to do this session. So let's get started. Any questions you have, you're welcome to keep in mind, and at the end of the session, you can write it down in the chat, and I'll be happy to answer for you. So I'll assume you can see my screen.
Yes, we can.
Okay, great. Right. So I'll take you through the immunity, like a little bit about the immunity that's generated with natural infection, and then we'll go through vaccination. And I think vaccination is probably what's more important for you all at the moment. Let me just adjust this. Right. Okay. So I'll take you through, these are the topics we'll be going through. Sorry. Vaccine immunology and development, current vaccines in the global, globally, vaccines in Sri Lanka, side effects, cautions, and contraindications. So that's really about practical things that people want to know. Then a few practical scenarios, and then we'll clear up a few misconceptions that people have. Immunity to COVID-19. Now, I was told that most of you have done some immunology, so I'll assume that you know the basic components of immunity, that you know that there is an innate system and that there is an adaptive system. And in the adaptive system, there's a humoral component, which is the antibody-mediated segment. And there is a cellular component, which is the T-cell mediated segment. Okay. So what happens during COVID-19 infection? Now, I'm sure you all heard that the virus enters through by binding through the ACE2 receptor, okay? And it's the virus spike protein, right? So in a virus, let me get a pointer, right? So in a viral particle, there are little protruding proteins that are called the spike protein. These are trimeric proteins, and these bind to ACE2 receptors and also other receptors, right? There are other co-receptors that are important, and these are present in the upper respiratory tract, especially in goblet cells and ciliated cells of the upper respiratory tract and type 2 pneumocytes of the lower respiratory tract. So that's how it gains entry. Now, ACE2 receptors are present in many cells of the body, okay? But primarily, the virus tends to enter into these sites, but it doesn't mean that it doesn't enter into other sites of the body, okay? So this is how it enters. You can see the spike protein binds through to the different receptors, the surface, the ACE2 receptor there. Then there are other co-receptors, so it binds and it becomes the endosome. And inside the endosome, there are different receptors that are part of the innate immune system. And we think that the innate immune system then gets activated through that, okay, with viral entry. So once the innate immune system gets activated, that activates probably several pathways, downstream pathways. There are different pathways which I won't go through. But you end up with an increase in innate immune cytokines. Now, I hope you've heard what cytokines are. These are small chemical messengers that take inflammatory signals, and either anti-inflammatory or either pro-inflammatory or anti-inflammatory signals between cells. And particularly cytokines like IL-1, IL-6, these are very powerful pro-inflammatory cytokines. These are elevated very strongly during COVID-19 infection, right? The other cytokines include IL-8 and TNF, okay? These cytokines then act to attract other immune cells, including macrophages and neutrophils. Particularly in the early phase, you have an innate immune response, okay? So the innate immune cells include macrophages and neutrophils, and these are activated by things like IL-6 and TNF, okay? So you get activated macrophages and neutrophils going to the lung, and these actually cause damage. Now, they cause damage to the infected cells, and if they are under control, if the damage that they cause is under control, then the virus load is cleared and the patient can recover. If, however, this doesn't stay under control, then the inflammation can continue. And it is a continuing inflammation that goes out of control that causes severe lung disease or the severe lung damage that we see in severe COVID-19 or in any kind of severe lung disease, right? Including influenza and other infections. So these neutrophils and macrophages will secrete more cytokines, and that leads to increased pro-inflammatory cytokines in bile and blood. Now, this has been shown. Bile is bronchoalveolar lavage fluid, right? So that is, if you pass a bronchoscope down the lung and wash out the lung with saline and take the cells that are in the lung out and analyze the cells and the cytokines that are actually in the lung, this is what they have found. And so in both bile fluid and in blood, they have found elevated levels of interferon gamma, IL-17, and IP-10, right? These are all cytokines. These two in particular are highly pro-inflammatory, okay? So this kind of innate immune pro-inflammatory response, as well as these tend to be acquired immune Th1 type response, leads to, ultimately, if it's not controlled properly, it leads to what is called acquired acute respiratory distress syndrome, or ARDS, right? And it is the ARDS patients who have got acute lung edema and impaired oxygen transfusion across the membrane. Those are the patients who get bad, okay? So that leads to pulmonary edema, epithelial cell death, vascular damage. There is thrombosis as well, right, inside the veins and the arteries, and ultimately that leads to multi-organ failure, right? So that is a very, very rough outline of what can happen during COVID-19. In general, now usually type 1 interferons, not interferon gamma, but interferon alpha and beta are considered type 1 interferons. They are what protect the body from viruses, right? But the virus seems to be interfering with interferon alpha, beta, or type 1 interferon production. So type 1 interferon levels tend to be not that high. Okay, it is elevated, but not as high as it should be in a viral infection. It is mainly the pro-inflammatory cytokines that we are seeing, particularly things like IL-6. So if we look at, this is showing, sorry, this thing keeps appearing. In phase 1, right, this is, so this is day 0 is like when viral replication starts, right? Or viral, so this is infection, and then this is when symptoms sort of start, right? From there onwards. So infection starts earlier, okay? And infection starts here, and the incubation period here can be anywhere up to 2 weeks. Okay, this is why quarantine periods also tend to be 2 weeks, and you have to do an exit PCR at the end to check whether you are PCR positive or not. Okay, so the infection is here, and you get infection of target tissues and local innate immune response. Early phase, so viral replication starts fairly early, and you get viral replication during this asymptomatic phase. And that is one of the reasons why COVID-19 is so infectious compared to SARS-CoV-1, right? Or just SARS, the original SARS, the first virus that emerged a while ago. I'm not talking about the Wuhan virus, right? I'm talking about SARS. That virus didn't replicate so much during the early phase. So it was the symptomatic people who were actually transmitting disease, so they could be quarantined before they transmitted. But in COVID-19, because people are replicating virus and being transmitters before they become symptomatic, this is why controlling this infection has been so difficult, and it actually spread to become a pandemic. Okay, so viral replication starts fairly early, and it occurs in the upper and lower airways. Now, the onset of symptoms is somewhere there, right? Usually from day 0 going on. Then you have like maybe about day 3 or 4, people will get admitted to hospital. Now, what about detection of virus? Is you can get PCR positivity. Antigen positivity usually starts a bit later, right? So in mild disease, you will get it there. But especially in severe disease, you can get it lasting for a long time. Now, early in our 11, we take as the late phase of the disease. Mild disease lasts for about 10 days and then clears up, 10 days to 2 weeks, and then clears up. Anything lasting after that goes into the late phase, and that tends to be the more long-lasting severe disease, right? Local immune response, as I said, the type 1 and type 2, type 3 interferons are seen in both, and that's seen very early, right? Because that's the innate immune response. Then innate immune activity in the lung, nasal cavity, or the lung, these are the chemokines. That is also seen during the first week or say 10 days. In the mild disease, you will see it only during the first week, and then it clears up, right? That's why they don't go into severe ARDS. It clears up, but in severe disease, this innate immune response tends to continue. Then if systemic impact is where you get systemic or bloodstream accumulation of interferons and other cytokines, and that tends to occur, especially you can see there are multiple cytokines that accumulate in the blood, many other chemokines, and that lasts for 2 to 3 weeks, especially in severe infection. In mild infection, that can occur for maybe in the 2nd week and then clear up after a time. In severe infection, that lasts at very high levels for a long time. And in viral sepsis, right, and ARDS, and when you get to fatal outcome, those cytokines are what really cytokines and the T cell responses that are going out of control. Those mild disease, you will get, I mean, the early phase is fairly similar in all, but it is this out of control immune response that causes problems for the people who get severe COVID. Now, why some people get severe COVID and some people don't, we don't really know. Possibly it has something to do with their in the initial viral load that they had. The other reason is, I mean, the most people we see going into severe COVID are the people with comorbidities. So particularly diabetes, hypertension, and heart disease. And I mean, if they're elderly. So those people generally have problems with their immune system. So, you know, their immune regulates severe infection. Right, so if you look at the virus, right, virus has many proteins, many antigens. So you can have, so there is the nucleocapsid protein, there is the S protein or the spike protein, there is the E protein or the envelope protein, right, and there is the M or the glycoprotein, right, the membrane glycoprotein. Okay, so there's, so it's not just the spike protein. All the you probably heard of the spike protein and thought, you know, right. So the vaccines give that one antigen. Okay, most of these vaccines give that one antigen. But natural immunity actually gives you immunity to all these different antigens. Okay, so we'll talk about that a bit. Remember, the spike protein also has this receptor binding domain, or the RBD, and that is where the Ac2 receptor actually binds. Okay, so the spike protein and the receptor binding domain are important because antibodies to those two will prevent binding. Right, so why are antigens important? Antigens, now I assume that you've done this for your undergraduate work. I was told you had. So basically it is the antigens, the many different antigens, or even a vaccine antigen that will be taken up by an antigen presenting cell, right? And presented on MHC class 1 or MHC class 2 to a T cell. Okay, this T cell can be a CD4 cell, it can be a CD8 cell. And if the vaccine, the antigen finds the appropriate T cell with the matching T cell receptor, this CD4 T cell will activate and become a mature T helper cell. If this is a CD8 T cell, it will activate and become a mature cytotoxic T cell. And these two have different functions. So in a cellular response that says starts at about day 6 to 8, the T cell will recognize cells that are infected with the specific virus, okay, and rapidly increase in number to fight the infection. So CD4 T cells will bring other cells of the immune system and also help B cells to produce antibodies that are specific to the virus. So the T cells bring in other cells, particularly like macrophages and other cells to help. But T helper cells also help CD8 cells to mature and help B cells to mature and produce antibodies. So that is their function. Okay, cytotoxic T cells or CD8 cells can directly destroy virally infected cells by recognizing them, because the virally infected cells will express this antigen on their surface and say, I am infected, right? The antiviral antigens will be expressed on their surface. What about the adaptive immune response from B cells, antibodies, right? Again, that starts at about day 6 to 8. This is in general, right? I'm not talking about COVID here. This is in general. The first time, so the B cells will again produce antibodies that are specific to that virus. Now, remember, they will produce antibodies to many different types of antigen, okay? So when you have multiple different B cells producing different types of each B cell will produce an antibody that is specific to it, okay? So if you have multiple different B cells producing multiple different antibodies, you will call that a polyclonal response. If you had only one B cell producing one antibody, right? Lots of it, but one antibody, that you would call a monoclonal response, okay? So you have a polyclonal response. And in your primary immune response, the first time you meet this antigen, you first get IgM antibodies, and this disappears usually within a few weeks. Then you get IgG antibodies that are produced about 2 or 3 days later, because the class switching happens, and last for a long time, right? That can be months to years, depending on the infection. Then you will have memory cells that are left over. So once an infection is over, there will be effector T cells and memory B cells that reduce in number, but a few memory cells are left. And the second time you get an infection, those memory cells will rapidly expand and deal with the infection much faster. So you get a much higher response from T cells and a much higher response of antibodies, right? That is the secondary immune response, adaptive immune response, okay? Right, so what happens in the adaptive immune response to COVID? Now, what I talked about earlier was the innate immune response to COVID. So there is a very high cytokine response, and if it's uncontrolled, you go into severe COVID. Now, what about the antibody response? What about the protective antibody response? So you get an IgM and an IgA. Those are two different classes of antibodies. That rises usually between 7 to 10 days. That's when you see it, okay? And that declines fairly rapidly. It comes down fairly rapidly. Usually in about 2 weeks' time, it has disappeared, okay? IgG starts rising, usually 9 to 11 days, like maybe a day or two after that. And from what we have seen, right, with that, those antibodies will last for at least 4 to 6 months in PCR confirmed patients, right? And we'll go into a little more detail about that. Now, antibody titers can be negative in approximately 5% of PCR confirmed cases. So not everybody who has PCR confirmed infection will develop antibodies. And what they think is that those patients are being protected by the cellular immunity, by the CD4 and CD8 T cells, and also by their innate immune response, which is why they have no detectable antibodies, right? So antibodies are obviously an important part, but not essential for protection. In asymptomatic PCR confirmed cases, there is only 15 to 40% of people will be negative for antibodies. So obviously the adaptive cellular component of the adaptive immune system is fairly important, or clear the infection very early in those people. This is what the dynamics of antibodies and all look like. So in the red line, you can see antigen, RNA, right? So antigen is detectable from within a few days of infection to up to, like we say, 2 to 3 weeks, but in some people it can last for months, right? But usually by day 14 to 16, maybe even up to 21, PCR becomes negative, right? Antigen detection, so say rapid antigen test would be a smaller window here, right? Particularly around the symptomatic period. But if you have more sensitive antigen detection tests, then yes, you can detect it maybe about there, right? IgM in the yellow line, you can see it rise at about 7 days, disappears by about 3 weeks. IgA rise again at the same time, but it goes up and disappears after a while, lasts a little longer than IgM. Remember, IgA is a mucosal antibody, right? So why you're getting IgA is because you have got mucosal infection in your nose. And to clear that mucosal infection, that's where the virus is multiplying, that's where that is the source of the infection from where you infect everybody else. That is where you're coughing and sneezing and everything is coming up. So to clear that infection, you actually need secretory IgA to come and clear the infection in your nose. And part of that secretory IgA will be present in your blood, and that's what people are detecting here. Okay, so that's why IgA becomes important to clear the mucosal component. Few days later, IgG in the green, IgG in the black will rise, and that is lasting for a long time. As I said, we seem to be seeing it lasting for 4 to 6 months, and then it seems to be declining. That data is coming out now. We are not sure how long it lasts, but it seems to be declining after that. T cells, again, rising a little earlier, T cell responses, and then declining over time. Okay. What we are seeing is that antibody responses are related to the severity of infection, right? High antibody levels are seen in severe disease, okay? So severe disease is associated with higher titers of antibodies, and it also takes a longer time to peak. The peak of antibodies is reached later in those with severe disease. It's a higher peak, but comes later. So the time to peak is about 90 days if it's severe. If it's mild infection, it's about 60 days to peak, and in asymptomatics, it takes about 30 days to peak, right? IgG levels will decline faster or disappear faster, come down faster in the asymptomatic infection compared to mild or severe disease, okay? This is data that has just come out very recently from Hong Kong. So this is neutralizing antibody titers in COVID-19 patients by days after illness to severity, right? So this is the overall picture. So you can see it rise, overall it rises to a maximum by about 30 to 40 days. And then you can see by about 210 days, they're still detectable, but it's coming down, right? In severe infection, you can see the peak occurs at about 90 days, and they have a titer of about, so this is neutralizing antibody, which I will talk about, right? Peak is at about 160, and then it comes down by about 210 days. So that's just over 6 months. So that's about 7 months. The neutralizing titers have dropped, okay? In mild disease, the peak is reached early, but you can see it's coming down faster, right? It's coming down to about 20% by 7 months. Asymptomatic people, they peak early, and then by about 3 months to, by 6 months, definitely their antibodies have disappeared. So in a way, having a severe disease does mean that your immune response tends to be stronger, right? And it is likely that it will protect you for longer. Asymptomatic infection doesn't, at least from the antibody point of view, doesn't seem to protect you that long. And in a lot of people, antibodies, as I said, are negative. But remember, these people do have a T cell response, and it is possible that the T cell response will protect them. Okay, we still don't know how long the T cell responses last in any of these people. That data hasn't come out yet. Right, so this is work done in Sri Lanka. This is from Javadhanapura, right? So again, the same thing. What they found was in severe illness that the neutralizing antibodies in these people, in this study, it rose earlier, right? Not later, but it's still high levels in severe disease. And moderate disease was a bit less, symptomatic disease low, right? And in mild illness had no detectable antibodies even 40 days since onset of illness. Okay, so what they're seeing is in mild illness, that the antibody response is low. So that finding is at least consistent. Right, now we come to the concept of neutralizing antibodies. Now, as I said, there are many antigens, right? And against all these many antigens, you can get antibodies forming. Now, that doesn't mean that all of these antibodies, so you can have, there are many anti-spike antibodies, right? So there are antibodies against the RBD or the receptive binding domain region. There are antibodies against different areas of the spike protein. There are different antibodies against different areas of the N protein, against the E protein, and so on. There are many antibodies, right? Not all of them are neutralizing. What does neutralizing mean? Neutralizing means it prevents the virus replication. Okay, it prevents the virus from binding and replicating, because sometimes the antibodies will just bind to the virus and do nothing, or maybe inhibit it a bit, but otherwise the virus is still able to replicate. Okay, at which point the antibody is not particularly useful on its own. Okay, so what we are really looking for and what the vaccines really want is to generate a neutralizing antibody response. Okay, so generating neutralizing antibodies is considered a functional correlate of immunity, meaning if you can show that a certain vaccine or an infection generates neutralizing antibodies, then you say this develops good immunity. Functionally, that's a good correlate of immunity if you can show neutralizing antibodies. Right? And this tends to, we say, provide at least partial resistance to subsequent reinfection. Not complete, because reinfection is happening, but at least partial resistance. So antibodies targeting the spike protein, especially in the RBD, within the, this is the receptor binding domain, within the S1 subunit, show the highest neutralizing capacity. This is the reason why the spike protein was chosen as the antigen for all these vaccines. Okay, this is the one that has the highest neutralizing capacity. Now, if we look at neutralizing antibody responses after an mRNA vaccine, in a person who has had previous infection, okay, after one dose will have a higher antibody response than a non-infected person after one dose. Why is that? Because now the person who was infected has already been primed. They have already met, their immune system has already met the virus, right? And they have already had their primary immune response. The first IgM, IgG response has already happened. the first dose of the vaccine is acting as a booster. So that is giving them the secondary immune response, right? So in an infected person, the first dose will give them higher neutralizing antibodies compared to a non-infected person after one dose, right? An infected person actually after one dose has greater or equal antibodies compared to a non-infected person after 2 doses. So actually, the best immunity in some ways that you can get that we currently know about is getting the infection and then getting the vaccine. Okay, that will give you really good immunity. Getting just the vaccine will give you immunity and you are protected. But if you get the infection and get the vaccine, that's actually better. That's what the studies are showing, right? Reduced neutralization capacity has been shown for some variants compared to the original wild type Wuhan virus. And we will talk about that later, right? But remember, although we talk so much about neutralizing capacity and the neutralizing viruses, non-neutralizing antibodies and T-cell immunity are also contribute to protection. And those are also important. Okay, because in people who don't have, neutralizing antibodies are also recovering from infection. So we know they are important. Right, so how do we evaluate them? Now I'm putting this slide in because it might probably important for you all just to get an idea of what can be done. So you can detect IgM, IgG, IgA, or total, right? Or different combinations of these. So you can do the rapid test, the cassette test, and the lateral flow immunoassays. These are rapid, qualitative, and if well done, and some of the good ones have a sensitivity of about 78%. ELISAs are available for both IgM, total, IgG, more sensitive, about 86%, and some of them are quantitative, some of them are qualitative. They're expensive, and you tend to have to do it by batch, so they're not always useful for diagnostic purposes in patients where you have to do one by one. Chemiluminescence immunoassays are also available. These tend to have the highest sensitivity of about 95. They're more expensive. You need the specific machines and all. They're currently being done, like for Peradeniya, the chemiluminescence antibody tests are being done in Anuradhapura because they have the machine. And again, detection need very high, 39, 40 CT values for the PCR. We can't discharge the patient, but if able to, or especially this happens, then we can actually discharge the patient. So then we are using this, right? Now to test for neutralizing antibodies, you need this, right? This is the gold standard, plaque reduction neutralization tests, right? It tests the total antibodies that can inhibit viral replication. Okay, and this is thought to have a high correlation with protective immunity. But for this, you need a safety level 3 lab. What can be done that uses surrogate virus, like they use a surrogate marker instead of the actual plaque reduction. Okay, that these are shown to have a high correlation with plaque reduction assays, and these are very rapid and safe, right? And this is what we are doing at the moment for research. This is also what Jayawardena is using. It's very expensive, but the assay is good, right? For T cells, to evaluate T cells, you can either do ELISpot, which is what Jayawardena is doing, or you can use flow cytometry. Right now, we don't have a flow cytometer at the moment, but if we did, then you can do T cell antigen-specific T cell responses and look at how long these T cell responses last in patients. Right. So talking about T cell responses, in COVID-19, both CD4 and CD8 responses are seen. Predominantly Th1 type. Now, I don't know if you know about the different T helper responses. When we talk about T helper or CD4 responses, there are different types. So you can get T helper 1, T helper 2, T helper 9, T helper 17, T helper 22. There are different helper responses. And those responses are characterized by the cytokines that are secreted during each of those, right? So T helper 1 response is characterized by interferon gamma, IL-2, and TNF. And these are the predominant cytokines we're seeing in this infection, okay? There are weak Th2 and Th17 responses also seen, right? S protein specific T cell responses tend to correlate with the anti-S antibody levels also, okay? Severe infection show higher memory responses in the convalescent phase. So it's very similar to the antibody responses, where severe infection is giving higher antibody responses. Severe infection is also giving higher T cell responses. Robust, that's good T cell immune responses have been documented 6 to 8 months after infection, but that's in one study. This finding hasn't really been correlated very largely in the literature, right? Most people look at antibodies. What has been found in several papers is that there are cross-reactive antibodies in 20 to 50% of individuals who have never been exposed. Now, this was done early on during the pandemic. They took T cells that were collected before the pandemic, right? And looked in those T cells whether there were spike protein responsive T cells, and there were, right? So 20 to 50% of the population, depending on the study, is showing T cells that are responsive to the spike protein that are probably cross-reactive. That means from other generally circulating endemic coronaviruses, normal coronaviruses just cause the cold, normal cold, those coronaviruses may be giving cross-protective immunity, okay? Through T cells. And that might be why some people get asymptomatic infection, some people seem protected even before the vaccine rollout happened, okay? Now, the vaccines, in addition to resulting in antibodies, AstraZeneca, Pfizer, Mrna, all of them have been shown to produce a Th1 biased CD4 and CD8 responses, which is very good. Right, so what actually happens? In its early pre-symptomatic phase, you get viral replication. In the symptomatic phase, in the mild disease, you will have an early mild disease happening here. You have the innate response predominating here, right? The humoral, you have a T cell response or the cellular response starting a bit early. The humoral response starts a little later. And mild disease, things shut down, like the innate response shuts down and everything shuts down if it's mild disease. If it's severe disease, this tends to continue into severe disease. Now this is showing cellular responses coming down, but that doesn't actually happen. It continues, and the humoral response also continues for a while, right? Now this, about therapy, I won't go into, but basically, what they're talking about is profit, because antibodies, now convalescent sera is from the serum from patients who have recovered from COVID-19 is being used as therapy, right? Because that contains antibodies that are protective. So convalescent sera is being used. So the timing of using convalescent sera, now a lot of antibodies have been manufactured that can be used. Antibodies against COVID-19 have been manufactured. That's including Regeneron that is being brought to Sri Lanka. It's very expensive. But those are antibodies. All of these are things that can be used at different times during therapy. You can't give it to every patient, right? At different times of the illness, depending on the immune response that is going on, you can try these therapies and see. Right. Now I put this so that you can see now there are different levels. So you have the immune homeostasis, there's the innate immune response, local immune, innate immune response. You have the systemic immune response, mild disease is down there, severe disease is down up here. And then you have most people recover, some people progress into what is called long COVID syndrome. And there are different syndromes classified as long COVID syndromes. Even mild disease, people with mild disease, sometimes even people with asymptomatic infection can go into what's called long COVID syndrome. That is post recovery, right? I mean, so they recover from the acute infection, and then there's an intermediate period from about 4 to 12 weeks. And then after 12 weeks, the symptoms are still persisting. That's called long COVID, right? So they have fatigue, shortness of breath, they can have chest pain, headaches, difficulty in thinking, difficulty in concentrating. It's a very debilitating illness, okay? So even people with mild infection can have this. Why this is happening is still not known, but it's only now the data is coming out. Okay, so just to introduce you to that concept. Right, so let's get on to vaccines now. What happens in a vaccine? So when you, basically a vaccine is doing what infection does, right? Without the risk of disease. Same thing, okay? During infection, antigens are introduced to your body, and the antigens are then taken up by antigen presenting cells like dendritic cells, presented to CD4 helper cells, and the CD4 helper cells will help CD8 cells to become effector cells, and those will be cytotoxic. The CD4 cells will help B cells that recognize this antigen to proliferate and produce, become plasma cells that produce antibodies or become memory cells, right? It is the source of this antigen is what is changing. It is either the vaccine that is just giving you the vaccine antigen, or it is the infection. And when you get the infection, not only do you get the vaccine, the antigen, but you get the replicative machinery of the pathogen as well. So you get the disease, right? The vaccine is just doing, you get only the antigen, not the replicative machinery. So you have no disease, right? So that this is basically the same thing that happens during infection is happening without the risk of infection, right? You have an antigen, you have antigen presentation, and you end up with CD8 cytotoxic T cells that are able to act against virally infected cells. You end up with B cells that are able to produce specific antibodies. Now, the other difference is vaccines. Okay, let's go to the vaccines next, right? So in development, now the COVID vaccines were developed quite fast, right? So this is something that people have been very concerned about. So traditional vaccine development takes 10 to 15 years. So you have preclinical trials, phase 1 takes another year, then phase 2 takes 2 years, phase 3. So this is initial safety check, this is safety check and efficacy. This is the large scale efficacy trial. While the large case efficacy trial is, so this will be like 20 patients, this will be like, 100 patients, this will be like 30,000 patients. Then this will be, infrastructure and manufacturing, and then this will be the long-term side effects profile. So those are the different phases, right? Now, the difference with COVID-19 was all these phases happened in parallel, right? One at the same time. So that's why it was so fast. Also, many of the preclinical trials had already been completed because the SARS virus, not the SARS-CoV-2, but the SARS-CoV virus is very similar, okay? And they had already identified that the spike protein binds of the SARS virus is what is used to bind to the ACE receptor, and that is what is used to get into the cell and so on, right? And when they studied this virus, they found it was the same. So the animal models for using the spike protein as a SARS-CoV vaccine had already been completed, okay? So much of this had already been done. The research into the new vaccine platforms, right? The viral vector platforms, the mRNA vaccines had already been done, right? The adenoviral vector platform had already been tried for some other disease and had already failed. I mean, it didn't work for that infection, but the vaccine platform was already available. So the only thing that actually needed to be done was to take this already preclinical trial approved or passed antigen and put it into a already available set of vaccine platforms and test it. That's all, right? I mean, it's not that simple, but that's what happened. So then the phase 1 trials, phase 2 trials all happen simultaneously and almost immediately from when SARS evolved, right? From when SARS appeared. And then infrastructure was built at the same time, right? It is the phase 3 that started a little later, and it is towards the end of phase 3 that we started getting data and approval, right? Manufacturing actually started because a lot of countries started using this before full approval was given. Russia, China, United Arab Emirates, a lot of countries started using these vaccines, also started early, right? Then you had now, okay? But all the safety, efficacy, monitoring mechanisms, those all stayed in place. So the WHO didn't give approval until the phase 3 trial data was available, right? Until the safety data was available. And you might ask, well, I mean, the safety data couldn't have been for very long. Well, that's true. But over the last, say, 100 years since vaccines have been available, and since the, say, 1940s or 50s, I think that vaccines have really made a major impact. the major safety problems of any vaccine have generally been seen within 2 months of giving the vaccine. Okay, they weren't seen years later. I mean, we've had the measles vaccine for over 70, 80 years now, right? People who got the first measles vaccines have already died of natural causes, right? So the safety signals from those, whatever vaccines were tested up to now, came within the first 2 months. So the vaccine trials that were conducted and had safety data up to 2 months to show that there were no other safety problems. Okay, so this safety monitoring and all, everything was done to make sure that these were safe for use. Currently, what's available in the global market? So you know we have the AstraZeneca 2-dose refrigerated. You have the Mrna and the Pfizer. These are RNA vaccines. These are viral vector vaccine. All these are 2 doses. You have the Sputnik, which is also viral vector, 2-dose. So the RNA vaccines need extra freezing, right? So you need -70, but they are stable at higher temperatures, like so at -18 or -25 for a period of time, depending on their constituents, right? So if you haven't reconstituted them, they are still stable at low temperatures for like even a week. So we can use them in Sri Lanka, although we don't have -70s all over the place, right? Then there's the Sinovac, which is an inactivated virus. Okay. Now the difference between all of these is the viral vector, RNA, all of these vaccines, they are either the RNA or the DNA for the spike protein. The Sinovac is the weakened or inactivated virus, which means that a lot more antigens are going in, right? So you're going to get a polyclonal response. These are all for the spike protein. So the only response you're going to get is for the spike protein, okay? Then you have the Novavax and the Janssen, which we don't have here. Of these, only the Janssen is a single dose. All the others are 2-dose vaccines, okay? In addition to that, now there's the Covaxin, which is from Bharat Biotech, and of course the Sinopharm, right? Again, a 2-dose inactivated vaccine. Okay, so those are the current vaccines that are approved now. There are more than 270 vaccines still in clinical trials. Okay, how do these work? So the viral vector vaccines, basically what they do is, instead of putting the spike protein in, you put the DNA for the coronavirus spike protein gene into a different virus, right? It's so the virus, the other virus, not the coronavirus, the other virus acts as a transport, a vector, a transport, right? You insert the spike protein gene into the viral genes of this is an inactivated virus. It won't replicate, right? Everything we're using now is non-replicative vectors. So you inject it into that, insert it into that, and this is what is injected into the people, right? The injected virus then uses the R cells machinery to express the DNA becomes RNA, RNA becomes a protein, and the protein is then expressed on the surface of our cells, and that is also taken up by dendritic cells and other antigen presenting cells to give rise to an immune response, right? mRNA vaccines just take it one step further, and it is the mRNA of the spike protein that is injected. mRNA, now none of this gets incorporated into our DNA. None of this gets, becomes part of us, okay? It just uses our cellular machinery to express the spike protein. That's all it does. Now, this doesn't last for very long either, right? Because DNA and RNA are both broken down by the DNases and RNases in our cells. So we are not going to express the spike protein forever. We just express it for a time long enough that we generate an immune response to this protein. Okay, because if we were to continue to express the spike protein in our cells, we wouldn't need a booster. We'd be boosting all the time, right? The fact that it stops is why we need a booster in the first place. So the mRNA then translates into proteins, and the proteins will cause an immune response. Right. Now let's look at vaccine efficacy. Now, vaccine efficacy is the percentage reduction in a disease in a vaccinated group of people compared to an unvaccinated group, right? the percentage reduction of disease in a vaccinated group of people compared to an unvaccinated group. So if you get a vaccine efficacy of say 80%, that means if you get vaccinated, you are 80% less likely to get the disease than someone who isn't vaccinated. It doesn't mean that 80% don't get the disease and 20% will get the disease. That's not what it means, right? Now, the vaccine efficacy estimates that we get are based on clinical trial conditions, right? And each clinical trial has its own unique conditions, right? So you can't directly compare the point estimates between clinical trials. You can't say that one was 95%, this one is 70%, therefore that one is better than this one. It doesn't work like that. That trial had a completely different set of conditions from which they got a value of 95. This one may have a completely different set of conditions, okay? So you can't really compare like that. So if you look at the point estimates, right, the Pfizer and Mrna had pretty high estimates. Then the Sputnik had an estimate of 92, Novavax 89, the Chadox or the Oxford 70, and the Johnson & Johnson 66. Remember these with one dose. And the CoronaVac had only 50%. The Sinovac was about 80%, right? So it's somewhere there. So what are we doing with the vaccine? As I said, the first dose will give you this primary immune response. This is if you haven't had an infection, right? If you haven't had an infection, the first dose will give you your primary immune response. And then as your primary immune response is going down, then you get your second dose and you get your secondary immune response. Now, what's important is not to give your second dose too early, okay? You give it too early, it will boost the primary. It won't go into a secondary, right? Giving it late is not too much of a problem, right? So you can give it even 2-3 months later and you will get a better boost. That is why initially the Oxford vaccine was given 1 month apart. Then they discovered that if you give it 3 months apart, the 2 doses 3 months apart, you'll get a better secondary immune response, okay? So a little bit of a gap is not a problem. Everybody tested 1 month apart because everybody wanted to finish the clinical trials soon, okay? Not that 1 month is the best gap to give, all right? Right, so once vaccine started to be given, you can see it was very effective. These cases before vaccination in America, right? And cases since vaccination, you can see a significant drop both in 18 to 54 and in the 80 plus years, right? So deaths before vaccination, and you can see deaths since vaccination, significant drop, right? So these were highly effective vaccines in reducing both the occurrence of cases and hospitalizations and death. Now, what you have to understand is that vaccines have made COVID-19 far less lethal, right? So it's much less lethal, but that just because you get the vaccine, if you're a very old person, doesn't mean that your risk of death is 0, okay? So these are Financial Times analysis of different data, okay? This is what it means, right? So this is your risk of death here, okay? So if a person who's 30 years old, I mean, even a 30-year-old without vaccination, there is a certain risk of death, okay? So has a risk of death of say 0.001. With vaccination, that risk drops to 0.0001, okay? So it's very, very low, but I mean, you can't say it's not there, no, you can't say it's impossible, right? But it drops to very, very low. As you get older, the risk of death increases. So say when you're about 80, your risk of death is about 1%, probably a bit more, right? But if you get vaccinated, the risk of death drops to the risk of death of an unvaccinated 50-year-old. It's something like that. So when you're everybody, it is worth getting the vaccine, right? It doesn't mean that your risk of death drops to 0. It means that it's now much, much, much less than it was before, right? So don't look at the 1 or 2 deaths that are happening in vaccinated people and say the vaccine doesn't work. That's what people tend to do. They look at the 1 or 2 data points that say, you know, vaccinated people died and say, these vaccines are useless. Look at that guy. He took the vaccine and now he's dead, right? The vaccine is not perfect. I mean, it doesn't reduce the risk of death to 0, but it drops your risk significantly. And that is what we are really aiming for, okay? Right, we'll look at vaccines in Sri Lanka. So we have the Pfizer preliminary point estimate. So from the initial clinical trials, preliminary point estimate was 95%. Real world data, that is, so this is from the clinical trial, right? And the clinical trial was done in places where there was not much disease transmission going on compared to the AstraZeneca. The AstraZeneca was done in places where there was heavy transmission going on, right? So the clinical trials themselves were very different. So real world data for the Pfizer shows this efficacy is slightly lower. Mrna is also slightly lower, but they're still very good vaccines, right? I mean, it's still more than 90%. AstraZeneca efficacy is about 74% in the real world. Then Sputnik and Sinopharm, we have no real world data at the moment, okay? So it's somewhere like 92 to, this one is about 86%. And the Sinovac is about 50%, okay? Now this is against getting the infection. All of these will protect against severe infection, almost to 100%. All of these will protect practically almost 100% against the risk of death, right? Now remember that was with the original Wuhan virus, okay? That's when it came, okay? Everything except the Sputnik is WHO approved. The Sputnik should be WHO approved, but they have not submitted the safety data in the format that WHO wants. So therefore, there's some problem. What is this saying? That the best vaccine you can get is any vaccine that is immediately available if you are not vaccinated, right? Don't be waiting for the Pfizer or the Mrna, because all the vaccines, all of them that are available, that are being given in Sri Lanka now are highly efficient. All of them produce protective antibodies. All of them will protect you against hospitalization. All of them will protect you against death for practical reasons, for practically the same efficacy, okay? And considering how widespread infection is now and how transmissible Delta is now, the time you spend waiting for a good vaccine, you will probably get Delta and die before you get the good vaccine, whatever you think is a good vaccine, right? The Sputnik, Sinopharm, Mrna, AstraZeneca, whatever, they are all excellent vaccines, very, very efficient vaccines at protecting against hospitalization and death. So get them, okay? Whatever it is, just get them. Don't be waiting for the American one. So what about vaccination in pregnancy? Now, none of the trials included pregnant women in the trial, but there were women who didn't know they were pregnant included by accident, right? And none of them had any problem, basically. None of them had any problem. So the current, and because pregnancy is a state of immune modulation, it's not so much immune compromise, but all pregnant women are more susceptible to infections, especially viral infections, than others, okay? And that's because the immune system in pregnancy has to change to accept or tolerate the fetus, because the fetus has to grow in the mother. So the immune system must change to be tolerant to that fetus and allow it to grow inside the mother. So that change makes the mother more susceptible to viral infections, especially viral infections. So pregnancy, you get COVID-19, you're in serious trouble, okay? So for that reason, it is now recommended that all pregnant mothers get the vaccine. In the first 3 months, in the first trimester, because that is the time of organogenesis, right? That is the time the organs of the baby start developing. Don't get it unless you are at high risk, right? And who are the high risk people? The obstetrician will tell you if you're high risk. But if you've got something that makes you likely to get very severe COVID, like have high like obesity, diabetes, pregnancy-induced hypertension, heart disease, some kind of pregnancy complication, then you should still get the vaccine, because most likely it won't affect the fetus at all. But if you get COVID-19, you will very likely get very severe infection, and there's a high chance of death, right? So in the first trimester, it's a balance, right? Between risk to the mother and benefit. Risk and benefit, you have to balance. And so talk to the obstetrician and see. Second and third trimesters, with the baby has already fully developed, the baby is just growing bigger, Okay, organogenesis has happened. So no problem. At any time during the second or third trimesters, you can get the vaccine, any vaccine, any vaccine. Okay, all of them are considered safe for pregnancy. Lactation, no problem, right? Get any vaccine, you will develop antibodies and you will pass those antibodies to the baby and protect the baby as well. Okay, so it is highly recommended that any mother who is lactating, even if you have just started lactating, baby is 2 days old, it's absolutely fine. Get the vaccine, you will be protecting your baby as well. Okay. So who actually can't get the vaccine? In Sri Lanka, now this advisory is not there in other countries, but in Sri Lanka, it is recommended that people who have very severe allergies, right, or who go into anaphylaxis. Now in Sri Lanka, let's put it this way. If you are allergic to the vaccine or any of the vaccine components, then you can't get the vaccine, right? That's a contraindication. That is there anywhere in the world. In Sri Lanka, in addition to that, if you have any other severe allergies to food, injectable drugs, cosmetics, anything, right, including the vaccines, if you have severe allergies or get anaphylaxis, then also you shouldn't take it. But this is not absolute, right? Vaccine allergy, you can't take it. But if you have like severe food allergies or something, talk to an immunologist or talk to your physician and see whether at least in hospital under supervision, you can get the vaccine, right? They might allow you to. Now, if you're not sure whether you have very severe allergies, then you most likely don't, right? Severe allergy and anaphylaxis is where you can't breathe, your throat has closed up, your blood pressure has dropped. Anaphylaxis is where you are treated with adrenaline, IM adrenaline, and you will be told this, you've gone into anaphylaxis, you're at risk of going into anaphylaxis again. And this is a life-threatening condition that is treated in the emergency units, right? Mild to moderate allergies, like you get a bit of urticaria, you get a bit of itching, you get a bit of eczema or scratching skin somewhere, you get rhinitis or you start sneezing for something, for dust or pollen or something like that. Mild allergies are not a problem at all, right? You can go ahead and get the vaccine without any problem. So these conditions, if you have asthma, no problem. Other lung diseases, heart disease and hypertension, diabetes, none of those diseases, renal disease, liver disease, none of those diseases are any kind of contraindication for getting the vaccine. All those people can get any of the vaccines, okay? And it is important that they do, because diabetes, hypertension, heart disease are the major risk factors for complications of COVID-19. So it's very important that those people who have them get those injections. Now, people with who are on medication will think, do I have to stop the medication? Do I have to, be off the medication for a while before I get the vaccine, after I get the vaccine? No, right? You just continue whatever medication you're on. If anybody is on high dose steroids, then that might have to be discontinued. So talk to your doctor. But otherwise, any other medication can be continued without a problem. Right. Now, a little bit about variants. Okay. So what happens with SARS-CoV virus replicates? There is no proofreading, right? In RNA viral replication, there is no proofreading or spell check mechanism. Okay. So mutations occur, right? Mutations like abnormalities in the replication process happen all the time, right? And the faster the disease is spreading in a place, the faster these mutations occur. Most mutations are actually bad for the virus, and the virus doesn't survive. Some have no biological effect, right? We see them, but they can't be used, right? A very few mutations, right, give a survival advantage to the virus against the host, right? Or they give the virus an advantage in the population that allow the virus to become dominant, right? And that advantage can be increased transmissibility, increased ability to escape the immune system. It not necessarily more severe infection, but just the increased ability to get into people and cause infection. This infection severity might be the same, right? So it is those viral variants that have increased transmissibility, increased replicative ability, those are the variants that we then detect as variants of interest. Okay, variants are happening all the time. Most of them will disappear. It is the variants of interest that become predominant, that take over because they have a survival advantage over the other viral particles that we see. So what are the viral variants that are going around? So now this was the original scientific nomenclature. WHO name is given here. So obviously our biggest concern at the moment, we had Delta, we had Alpha, right? Now Alpha is disappearing. Now we are getting Delta, right? So Delta has sort of taken over. Now I think about 60% of what's, Colombo is almost completely Delta. About 60% of what is isolated in Canada is also Delta now, okay? America had an Epsilon variant. Now I think the WHO is monitoring a new variant called Mu. They don't know if it's going to be a variant of concern yet or not. So, you know, variants will pop up from time to time. At the moment, our concern is Delta. Right, so what about efficacy against Delta, right? Now against Alpha, most of the vaccines were actually quite effective, right? Let's go back. Against Alpha, most of the vaccines were quite effective. Against Beta, they actually weren't, right? But luckily, in some sense, Delta actually spread faster, right? Before Beta could take over the world, Delta took over the world. Now, against Delta, the efficacy is reduced, right? AstraZeneca, you have about 50, this is real world data, about 58 to 67% efficacy after you get both doses, right? Pfizer, 64 to 90%. Now this huge gap is because there were two different studies and they gave very different results, right? So, but it's somewhere between there. Again, if you get both doses. Moderna, there's only one study, it says 90%, but maybe another study will do and it will be less, right? But again, both doses, right? Sputnik and Sinopharm, at the moment, we have no data. But what we're seeing, right? Now, this is the first column will be Alpha, second column will be Delta. And what we're seeing is compared to the Delta variant, right? The efficacy compared to Alpha is reduced for all the vaccines compared to the Alpha variant, right? So most likely the efficacy of, and usually by about 5 to 10 percentage points. So most likely what we will see is that the efficacy of Sputnik and Sinopharm are also about 5 to 10% less against the Delta variant compared to the Alpha variant. Okay, and remember that is after you get both doses. Now, one of the reasons why Sri Lanka is seeing this massive wave of Delta is because one thing, there's obviously a massive unvaccinated population, but even though our vaccine drive is going forward, the single dose population is the largest still, right? And a single dose is actually not going to protect you very much at all, right? Protection is like 20% or something. You need both doses to have even a 60 to 70% protection, okay? So getting both doses is very, very important. How do you stop the spread of variants? Practical real world things, same way you stop anything else. Now the variants that happen, so Alpha arose in England or in Wales, when there was very rapid transmission going on in England, right? Beta arose in South Africa when there was very rapid transmission, because if there's more people getting infected and transmitting the infection, then there is more opportunity for a variant to arise. There's more replication, so there is more chance for a variant to arise, right? So if we want to limit then Delta happened in India when India was out of control, right? So if we want to control the rise of variants, we need to control replication. We need to make sure that the disease isn't spreading very fast, right? And so vaccination alone is not enough. We need to have public health measures to protect the population as well. And there are other reasons for that as well. I'll go through them. Maintain 1 to 2 meters, right? That is essential. Hand hygiene, masks, and masks on your face, right? Not on your chin, not hanging off your face, but nicely fitting masks. For Delta, now they recommend double masks, right? A surgical mask with a cloth mask over it, right? Nicely tied so that it fits your face. Don't touch it all the time. Perform hand hygiene. Stay away from crowded places. Be very careful with your family and the elders in your family. So these practical public health messages are extremely important. Don't rely on vaccines alone, okay? So the viral load is about 1,000 times higher in people infected with the Delta variant than the original Wuhan virus, right? The viral load. Now, what they have also shown that even if you get the vaccine, the viral load in your throat is actually equivalent to those who have not had the vaccine, right? So the viral load in Delta is very, very high. Delta is more contagious. Delta causes more severe disease in unvaccinated people, right? So you need both doses to minimize this viral load that you are exposed to. Wear a face mask properly, maintain social distance, avoid crowded places, hand hygiene, get vaccinated. Okay, very important. Right. I'll skip over that in the interest of time. Important to note that in Sri Lanka, of the deaths, more than 90% were in unvaccinated people. Okay, so a certain percentage of vaccinated people are dying. Most of them had one vaccine, but some of them had 2 vaccines also. Now, even in healthcare workers, we are seeing a breakthrough infections, not necessarily severe infections. But part of the reason for that is because the healthcare workers got their vaccines in January, right? January to March. And it has been shown that AstraZeneca and Pfizer, those are the only 2 we have data on, that the efficacy starts to drop in about 6 months. So that will be the other reason, okay? Right, so vaccination, full vaccination is considered 14 days after receiving the 2nd dose. Okay, that's when you're fully vaccinated. Reduced risk of getting infection. Highly reduced risk of hospitalization, getting severe disease, complications, and death. Okay, the rate will still depend on age, comorbidities, and immune status. So if you're immune compromised, your immunity still won't, even with 2 doses, won't be as great as somebody who's healthy. Reduces the risk of transmission. Vaccination does reduce the risk of transmission, right? An Israel study shows that 40 to 78% reduction in transmission of the alpha variant. But remember, the viral loads were much less. The Delta variant, we still don't know whether it has an effect on transmission from the vaccines. Okay, so public health measures are still very important, right? Because with the mask, you can prevent transmission. Otherwise, you can still transmit. So wear the mask. Otherwise, even if you're asymptomatic, right, or mildly symptomatic, you can still transmit the disease to other people. How long do, say, the vaccines protect? We don't have exact data. Real world data is showing that the Pfizer and the vaccine, AstraZeneca dropped by 6 months to 84 and 67%, right? A third booster dose is still not recommended for the general public or for healthcare workers, right? Boosters are only, third dose boosters are only recommended for the immune compromised populations because they show significantly lower antibody levels even from the 2nd dose. So they, people with malignancy, dialysis, transplant, those patients, there is a recommendation for a 3rd dose. But everybody else, the WHO and even the governments will not recommend a 3rd dose, although Israel is giving a 3rd dose, because there are so many people who have not even had the 2nd dose, right? So, you can't talk about a 3rd dose for a certain portion of the population now. So that is why, but immunity does drop in about 6 months. So what is herd immunity, right? Herd immunity is if only a few people are vaccinated. Now, it doesn't have to be vaccinated. Even if you've got the infection and you're immune, right? If you're immune, if a few people are immune and one person, the orange chap, is infected, the orange chap can infect other people very fast, right? Because there are a lot of susceptible people, okay? But if many people are immune, vaccinated, right? Lots of people are immune, then the disease doesn't spread as fast and it's much easier to contain, okay? But obviously the percentage of the population needed to achieve herd immunity will depend on the rate of transmissibility and so on of the disease. Now for the alpha variant or the original Wuhan virus, the herd immunity percentage was something like 70% or something, 70%, I think, right? But for the Delta, because it's so much more transmissible, you need something like 87% to be immune, right? So now we need to aim for more vaccination and make sure that the bulk of herd immunity. Okay. Right, so a little bit on side effects caution. Main side effects, now I've written, now what I put here is the sign of side effects, but they're very similar across most of them. Local reactions, pain at the injection site, headache, those are the main ones, right? And it was less common in the elderly, more common in young people. And, you get over it in about 48 hours. Most of the vaccines are similar in their side effect profile, and there was no major complications there. Who can't get the vaccines? Allergy to any of the vaccines or their components. In addition to which, in Sri Lanka, they have said people with uncontrolled epilepsy can't get the Sinopharm. People with guillotinias can't get the Sputnik, Sinopharm, or the Covishield because it's not validated for them. It hasn't been tested in them, right? So those are really the only categories of people who can't get the vaccine. Everybody else can, okay? Who do we vaccinate with care under medical advice? People with bleeding disorders, right? And that is because you're giving an intramuscular injection and that can bleed, okay? So those you can still vaccinate, but maybe in a hospital. And people who have uncontrolled severe diseases, right? And now those people are generally in hospital anyway, right? So if you've got severe uncontrolled liver disease, decompensated liver disease, decompensated renal disease, severe heart failure, if you're very ill, right? Those kind of patients will be in hospital anyway. So they would be, if at all, vaccinated under medical care, right? So those are vaccinated under medical advice. Now, the major side effects of concern that actually showed up later was the blood clots, right? The venous thrombosis that came with AstraZeneca and also the J&J, the Johnson & Johnson vaccine. Now, that was predominantly in females under 40 years. But if you look at the risk of getting thrombosis, it was 0.9 to 3.6 per million doses. Whereas if you get COVID, the risk of venous thrombosis due to COVID is about 60 times to 230 times that risk. So there was no point now, although Europe can shut this down for under 40 females, there is really no point keeping yourself at risk of getting COVID and that high risk of getting thrombotic complications just to avoid this. Okay, so yes, there is a risk of thrombosis, but it's a very, very small risk. The other side effect that has come to light more recently is myocarditis, okay, in the Pfizer and the Mrna, in the RNA vaccines. This is inflammation of the heart muscle. This is a generally very mild disease, right? And you're in hospital for a few days. I think the first death due to myocarditis was recorded in New Zealand recently, but otherwise until then, nobody had died of it, right? So the risk is primarily in young males, under 30 males. So you get 40.6 per million doses. Young females, 4.2 per million, more than 31 to 2.4 per million, right? Whereas the risk of myocarditis or cardiac complications due to COVID is about 7 to 23% in any patient, okay? So yes, there is a risk of myocarditis. Up to now, only one hasn't recovered. Everybody else has recovered. It's a very mild infection, it's a very, very mild complication that needs medical attention, yes, but still you can recover. And you're at much greater risk of getting cardiac complications with the infection than you are from the vaccine. So these are not reasons to not take the vaccine. The vaccines are still the best hope we have of getting through this pandemic, right? Right, so a few practical scenarios before we wind up. If you have had COVID before vaccination, still get the vaccine, right? Get any vaccine that is available to you. You can take that vaccine anytime after about 4 weeks from recovery, right? Take both doses, although one dose may be sufficient, but if you can get both doses, then take both doses. But even if you had COVID-19 or 4 weeks after recovery, anytime after that, even if it's 6 months, 7 months after that, you can get the vaccine, right? Any vaccine. If you got COVID-19 after the first dose, again, wait for 4 weeks after recovery from infection and then get the second dose. Now about mix and match of vaccines, which people are trying to do, though as I think you all probably know, the only data that's available is for mixing the AstraZeneca and the Pfizer or the Mrna, right? Mixing and matching the other vaccines is not encouraged at all. It's discouraged because we really don't know what will happen, right? We don't know if it will boost. We don't know how much it will boost. So and now I think all the vaccines are available, right? Even the next one I think is that, is about the Sputnik, because I think the Sputnik second dose had been delayed, but I think we've got the second doses. We got 15,000 of the second doses now, because the first dose and the second dose of Sputnik are actually two different viral vectors, right? So they're different doses. You can't give the first dose the second time around also. They're two different injections. But now that has been brought, so even that shouldn't be a problem, right? Stick to the vaccine that you've been given. At least then we know what's happening with your immunity, okay? Right, so misconceptions to wind up. Autism, no, you do not get autism, right? Now the autism misconception started with the measles vaccine when some idiot in some country went and proposed that somebody got autism and proposed that this could happen, and immediately the anti-vax, that's actually how the anti-vax movement really started up. Proposed that, and vaccines can cause this, and then it was completely disproven at that time, right? Completely disproven. But that, one idiot was enough to stop people from taking up the vaccine, to really strengthen the anti-vax movement. For any vaccine after that, for people to immediately ask, do you get autism from this? So much damage was done, right? So do these vaccines give you autism? No, they don't. Okay, no. Do the vaccines change your DNA? No, they don't, right? They don't go anywhere near your DNA. Some of them just use your cells machinery to make proteins, and then they are degraded and disappear, okay? Development was rushed without safety precautions? No, right? All safety precautions were taken during each of the clinical trials, right? Cause infertility? No, this was again some other idiot, right? So somebody else proposed that, somebody in Germany, I think, proposed that some protein in the virus is similar to a protein in the reproductive tract, and therefore any antibodies against that protein might cause subfertility and so on. There is absolutely no evidence for that, right? Absolutely no evidence. And people who have gotten pregnant after taking the vaccine have gone on to successfully become pregnant and successfully deliver their babies. And so there is absolutely no evidence of infertility whatsoever, right? So you can take it. You don't need to, once you take the vaccine, you don't need to delay getting pregnant at all. You can, even the next day, you can go ahead and try and get pregnant. There's no reason to delay. So infertility, no, right? You can get COVID-19 from the vaccine, no. None of these are live attenuated vaccines, right? So there's not even a small risk. Even the ones where the virus is present are inactivated viruses, right? Vaccine immunity affects other diseases? No. Right? So no vaccine affects the immunity of other diseases. If at all, vaccines like the BCG enhance immunity to other diseases, right? You will get antibodies to this. It doesn't affect antibodies to anything else. You can mix vaccines. We don't know, right? So we know Pfizer and AstraZeneca, you can mix them, but the others we don't know, right? So don't go around mixing them. You need to stop other medication when taking the vaccine? No. I mean, if you're on high-dose steroids or you're on cytotoxic medication, then yes, you can talk to your doctor about, maybe cutting down the dose while you're, for about a month, 2 weeks before taking the vaccine, and then, for 2 weeks after the vaccine. But other medication can be taken. Should be avoided in people with other diseases? No, right? Those are the people who should get the vaccine. Right, so in summary, both natural infection and vaccination provide very good immunity, right? But reinfection or breakthrough infection after vaccination is possible, especially with the variants, right? Because the immunity does, depending on the variants, right? Or doesn't protect completely against the variants. Disease transmission is still likely, especially with the variants. So public health measures are essential, right? every time you see, I mean, don't get together, don't eat together, don't share food. Try and stay away from people as much as possible. Do things online as much as possible. Don't do face-to-face discussions. Keep distance, right? That's the safest thing you can do for other people. Even if you're not worried about yourself, right? You might be young and healthy, congratulations. But for the other people, the best thing you can do is stay away from them, okay? Vaccination or infection needs to cover more than 80% of the population for herd immunity, right? In highly transmissible and highly infectious variants. And all vaccines in Sri Lanka are safe and provide good immunity. So get whoever, I mean, you will have elderly people in your families who are like, today headache, today this hurts, today that hurts, I don't want to get it. Encourage them, right? Encourage them, tell them it's the safest thing to do, tell them there might be a few side effects, but it'll be very few. You look after them and encourage them to go and get the vaccine, help them to go and get it. If they are unable to travel, then, talk to the MOH and get one of those mobile things to come and give the vaccine at home, right? So do the best you can to get the people around you vaccinated. Right, thank you very much. And if people are still around, I am happy to take questions.
Thank you very much, ma'am, for the very informative explanations. Now we have reached the end of the program and hope you got a better understanding of the topics that discussed today. If you have any questions to be clarified, you can unmute your mic and directly ask questions from our resource person, or else you can put your questions in chat box as well. And also, I would like to remind you that we'll post the link to the feedback form in chat box. So we invite you to use that link to give your feedback to improve our upcoming events. Ma'am, I have a question. How much time take to get full protection after the second dose?
Usually 2 weeks. So welcome.
Madam,
yeah.
Thank you very much for your informative session, madam. My question is, madam, after getting 2 doses, if you get the COVID disease, what kind of response we get, madam, regarding the graph I'm referring?
Right. So basically, you will get another secondary immune response, right? So you don't call it a tertiary. You get repeated secondary immune responses. But what we hope is that your antibodies will increase fast enough and your T cell responses, because you have memory, you have memory cells now. So because you have memory cells, that the rise of antibodies and the rise of T cells will be fast enough that the infection will be controlled very early before it gets to a stage where the inflammation is out of control. So you won't go into severe disease. You will be able to recover at a mild disease stage. That's what we hope. That's what we expect.
Yeah, thank you, madam. Madam, what if a different variant is going to cause the infection? Will it be the same cycle or different cycles?
Depends. Like a variant will give rise to some some of the antibodies and T cells responses will be the same because the variant is not a completely different virus, right? So I would say even most of them will be the same. So you will get a secondary immune response. To the newer epitopes or to the newer antigens, then yes, true, you will get a primary immune response, and that can take time. So for that reason, like if the antibodies you had previously are still neutralizing or even partially neutralizing, then you might control, right? If the CD8 T cells and the innate immune cells that you have from your previous exposures are capable of controlling, then you might control. But for full neutralization, you might need these primary immune response new antibodies that are forming to form, which might take 6 to 8 days to happen. And the rise might take 2 weeks. So the course of disease in a new variant, especially if the variant is very different, might take a longer time.
Thank you, madam.
Yes. Right, I've got some questions. Is there, if that immunity drops after 6 months after getting the vaccine, do we have to get vaccinated again? Israel vaccinated their entire population they Mrna, Pfizer, and they gave both high levels of infection again. One reason is because the vaccine doesn't protect too well against Delta, and the other reason that they found was because immunity was waning. So Israel, despite now, WHO has not recommended a third dose yet, okay, to anyone. But Israel went ahead and is now giving the third dose to everyone, right? And they are seeing a drop in infection. In Sri Lanka, the earliest to get vaccinated were the healthcare workers. And in healthcare workers, we don't know their immune status yet. From the work that we have done, we know that they see most of them seroconverted. I think it was 97% seroconversion. So most of them did develop antibodies. How long that's going to last, we don't know. We've got another sample collection in September. So we'll see how high the antibodies are at that point. That's, I think, the 8-month time point. But the thing is, do we give another dose to them when there are people who haven't got the vaccine at all, right? So it's really more of a public health decision. Ideally, if we detect that immunity is coming down, and that protection is coming down, and especially against the variants, because protected against the variants as well. Okay, so like if you had very high antibody levels, you're more protected if you have high levels of viral load in the wards all the time, because the hospitals are full. Yes, we should be giving a third dose, but can we afford to do that when most of the population even hasn't had a second dose? Probably not yet. Okay. Right. Right. Can someone get infected several times with different variants, though he is fully vaccinated? Theoretically, yes. Right. We don't know. Even with full vaccination, you can get the infection. And as variants arise, newer variants come in a way by a process of natural selection, because now the variant has, as and more people get, so yes, people will still likely get infected. Variant is not at least partially immune. Probably the death rates and the hospitalization rates will be low because of the vaccination, right? And also possibly if the variant that is completely immune escaping the vaccine protection comes, they might have to develop a new vaccine. That's variants. Yes, eventually, if you got exposed multiple times and your immune levels, through natural exposure and through infection, you boosted your immunity high enough, you probably stop getting infected simply because your antibodies and your effector cells, T cells, are so high. But you can't say that at this point you will stop getting infected. Eventually, this will become endemic. It will become like the flu virus or like dengue, and we will all, eventually all of us will get COVID. I don't think there's a way of escaping that. A person has no symptoms of corona, but after getting vaccination tested positive with corona corona with severe symptoms. What may be had no symptoms of corona, but after getting tested, after getting the vaccination, tested positive with corona with severe symptoms. So that basically means that after vaccination, they became corona positive. So, I mean, if you're asking whether the vaccination could have given corona, no, because none of the vaccines have attenuated virus. They're either inactivated, which means they're basically dead, or components, right? And there is no virus there. So if they got the vaccine, I mean, if it's after the first vaccine, that's entirely possible, right? Because the first vaccine really isn't going to protect you that much against COVID-19, certainly not against the variants, certainly not against Delta. If it's after the second vaccine also, then maybe they have some kind of immune compromise, especially if they're diabetic. The vaccines are really not going to protect you that much against severe infection. If you have, I can't really understand how they had, first the no symptoms and then the severe symptoms. So if there's something you would like to clarify on that, please message me again. Is it necessary high protein diet for COVID patients? What is the recommended diet? Not necessarily a high protein diet, but a nutritious diet, right? So a balanced diet with all your vitamins and minerals and things like that. A high protein diet isn't really going to help anyone at this point of time. I mean, all these vitamin syrups and immune boosting, this and that, and all these things are not going to help you, right? A balanced diet with enough protein, carbohydrates, fats, make sure you're not vitamin C, vitamin B, or AD deficient. You have minerals in your diet, you're taking vegetables and leaves, fish, meat, something like that. That's really what you want. When you have acute COVID, hydration is important, right? Do not become dehydrated. But I mean, especially in an ill patient, they might not be able to eat very much. So if they're not able to eat, then anything that they can tolerate to maintain their energy, hydration, that's really what's important, right? Giving them high protein is not going to help them too much in the acute stage, okay? Right. What happens if a person gets vaccinated in the same period while he has been infected with COVID-19? There's no harm, right? There's no harm, but the thing is, if you get the vaccine today and then 3 days later get infected, your body won't really tell the difference, theoretically, right? I can't say for certain, but theoretically, your body won't tell the difference between the COVID antigens and the vaccine antigens. Just antigens, to the body. So basically, you will get a primary immune response if it's the first dose, if it's your first exposure. And the vaccine won't work separately. You won't get, one immune response from the vaccine and another immune response from the infection. So it's not 2 shots. So you can get the infection, you will get a primary immune response, but you will need your booster later. Get that booster. Right? But having the vaccine is not going to be harmful to you. I mean, it's not going to, especially if it's early on during the infection, the vaccine won't have had time to work at all, right? So you won't have any antibodies or anything. So it's not going to actually change the clinical outcome of your disease in any way, okay? Is there a serotype replacement or pneumococcal is there a serotype replacement for pneumococcal conjugate vaccine? Are there any similar scenarios for this viral vaccine as well? Pneumococcal conjugate vaccine serotype replacement. I know that there are different combinations of serotypes for the pneumococcal conjugate vaccine. And there are different combinations depending on what is prevalent at the time. They give different vaccines in other countries. We don't use the pneumococcal vaccine too much. In viral vaccines, let's see. No, the flu vaccine, so every year the flu vaccine, so that's against the influenza virus, they will look at the circulating strains of influenza A and B. So whether it's H1N2, H3N5, whatever. And so they will include what they predict to be next year's flu strains so 2 of the influenza A strains and 1 of the influenza B strains will be included in the flu vaccine for the year, what they predict to be what will circulate, right? So every year, and for the Northern Hemisphere, there's one flu vaccine. For the Southern Hemisphere, there's another flu vaccine because the viral strains tend to differ. So every year, the flu vaccine does change according to strain. But other than that, it is, I think, the meningococcal vaccine, the pneumococcal vaccine, the capsulate organism vaccines that really have this serotype business, right? Other than the flu vaccine, I can't think of any viral vaccine that where they change the serotype that often. Will we have to go into that with COVID-19? Yes, a lot of people do think that we will have, I mean, we will need an annual, at least an annual COVID jab, like the flu vaccine. I mean, we don't get the flu vaccine in Sri Lanka, people don't take it, but in the northern, I mean, in the temperate climates, people do, right? It's, I mean, for over 60 years, it's almost mandatory. But this COVID vaccine will probably may become an annual vaccination, you know, for most people. And eventually, will it become a variant-based vaccine? Quite possibly, yeah, quite possibly. Right. Do some healthy people do not produce antibodies after vaccination? Yes, some don't. How do people know whether they do not get antibodies after vaccination? You have to test your antibodies, right? Now, this has not been recommended to be done for anyone, right? Because even if you don't have antibodies, no vaccine, even the most efficient vaccines, I mean, the live attenuated vaccines tend to be the most efficient at seroconversion. Even the most efficient vaccines are not 100%, right? There will be a certain portion of the population that don't respond with antibodies. These vaccines are the same. So if you don't seroconvert, it is done in the private sector, but the sensitivity of those tests that are currently available are very, very variable, right? I mean, you might have undetectable levels of antibodies that are in fact protective. It's just that the assay is not sensitive. I don't think so. Because even if you haven't developed antibodies, you've probably developed T cells, right, against this infection. And even if you don't have antibodies, is there a guideline that says go and get another vaccine? No, not for COVID. Some of the other vaccines have that, but not for COVID, right? So while there is a possibility, right now what we're seeing is that in a healthy adult population, more than 97% will seroconvert. Most likely the other 3% will have at least T cell responses, and those T cell responses seem to be lasting a long time. So for now, don't worry about thinking whether you're protected or not. If you've got the vaccine, you should be, okay? Is the rapid antigen test, which antigen is based for the test? I'm actually not sure about that. I know we use it, but I'm actually not sure. I think it depends on which company rapid antigen test available. But I think that you'll have to check which company assay you're talking about and then check for the antigen on that. I'm sorry, I'm not sure. What are the complications of infection of infected person which get after recovery? There are actually many complications. I'm not involved in the clinical management of these patients, so I'm not, you know, fully versed on that. But one of them, as I said, is long COVID, where you get persistent symptoms. I mean, the symptoms of the disease persist for more than 12 weeks. Okay, so you can get cough, shortness of breath, chest pain, fatigue, difficulty in concentrating, all those complications like that can last for a long time. And there are actually support groups now for people in developed countries, for people who are going through that. You can also get post-ICU syndrome, which is a little like post-traumatic stress disorder, where after being in an enclosed, you know, in ventilated space for a long time, you get different symptoms. You can get lung fibrosis and lung inflammatory disorders, and, you know, persistent lung problems that last for life after that. I think, I can't remember if there are thrombotic complications, like, so arterial, you can get arterial and venous thrombosis, but whether that lasts after the acute infection, I'm not sure. So recovery, the older you are and the more the how does after recovery, how does vitamin D help COVID-19 patients? So there were trials on vitamin D, and I don't think that they showed anything conclusive as far as I acts on the immune system to increase macrophage function is one of those functions. Right? It's an immune people in Sri Lanka, especially the older people, tend to be vitamin D deficient, especially if they don't get enough sunlight, if they don't the vitamin, okay? So the vitamin D in COVID-19 was given, I think, to reduce hospitalization, increase viral clearance, but I don't think that they had, there were many trials, but I don't think they had any conclusive evidence on that. I think what finally came down to for prophylactic use, what has now been approved is ivermectin, right? Ivermectin is, I think, what just finally came as one of the therapeutics that could be used. Sorry, I'm not very conversant on the clinical aspects of treatment. I don't treat patients. I'm sorry. Right. Do we need to avoid getting tired even after the recovery for COVID? For any viral infection, right, or any severe infection, getting excessive exertion will likely send you into rest. A lot of rest is important. Otherwise, like, although you might physically start to, your symptoms may start to reduce, the inflammatory tendency of your body hasn't actually gone back to normal for a long, doesn't go back to normal for a long time, okay? And you need to make sure that you allow your body time to fully recover. The other thing is that to the alveoli, to the gas exchange, to the vascular endothelium, all of that has to heal. Otherwise, you're just, in an inflamed state from your vessels to your lungs, to your epithelium, to everything, right? All of that has to heal. And healing takes a long time, okay? Regenerating a basement membrane, regenerating the cells. At that point, good nutrition, yes. Not necessarily high protein diet, but a balanced diet with vitamins, minerals, everything included, okay? So avoiding immediately post in your recovery phase, a lot of rest, a lot of fluids, good balanced diet, sunlight, those things, yes, I would say are very, very important, right? Don't exert, don't allow them to exert. And it can take months, slowly get back to normal, yes. Because otherwise there is a chance for relapse. Right, I think I've gone through all of them.
Ma'am, we have some direct questions from the chat.
Yeah.
Do variant strains affect the buildup of herd immunity?
Yes, they do. Because now, so originally from the original Wuhan virus variants, from the original Wuhan virus transmissibility and everything, the herd immunity level, so herd immunity will depend on a few things, right? The population density, transmissibility of the virus, rate of infection, the density of like distance of transmission, mode of transmission, and a few other things. So now the original Wuhan virus, it was considered a droplet infection. R0 was like 2 point something or 1 point something. That is the number of people that get infected from a given person. And so herd immunity was estimated at about, I think, 70% or something. But now if you take Delta, which has gone all over the place, R0 is much higher, right? I think it's like 4 or 6 or something. Much higher, so it's much higher transmissibility. Population density, so herd immunity will also vary according to population density, but if we take the population, the infectivity before symptoms occur, right? So Delta is much more infectious, okay? So for that, you need, so for Delta, therefore they've calculated something like 87% need to have herd immunity because it is so highly transmissible. And now, I mean, they also later on, after when the other variants started rising, they also included aerosol transmission precautions as well. Initially, it was only droplet transmissions, but then they included aerosol transmission precautions. So as the variants change, if those dynamics change, if the transmissibility, if you will have better transmissibility, infectiousness, etc., characteristics, because they are becoming dominant, no, that is their feature, no? So with that, the population that needs to be immune for this thing to be controlled will also change. Yes. I put another message. After getting vaccine, is it necessary to bed rest, or is there any safety precaution to get by a person after vaccination to get rid of complications? You don't need bed rest, right? I mean, if you've got fever and you're feeling tired and miserable and ill, till you feel better, stay in bed, right? But if you're feeling fine, then you can go to work as normal, right? Is there anything you can do to avoid complications? Not really. Right? I mean, don't take steroids, right? I know some people do that. They take steroids and antihistamines and things and go for the vaccine to prevent the side effects. Don't do that, okay? Because the steroid will automatically just drop your immune response. It won't drop your immunity, but it will drop your immune response to the vaccine. That makes it pointless, okay? So don't take anything except maybe a Panadol. But if you feel okay, you're fine. You don't need to rest. You're fine to go to work. If you're, if you have like vomiting or diarrhea or a bit of fever or something, take some Panadol, rest till you feel better, and then you can go to work. Otherwise, there's nothing else in particular that you need to do. If you're acutely ill, like not necessarily with COVID, but you've got fever or, for something else, right? You got fever. We won't know if the side effects are because of your acute illness or because of the vaccine. And then you can get like urticaria and other allergic reactions that we won't know whether it's because of the vaccine or because of something else, okay? Because part of the allergic reaction is fever, okay? So we won't be able to tell. And that's why they keep you for 15 minutes after giving the vaccine. That's to check for allergies, okay? And if you suddenly get a bout of fever, then you have to be admitted to hospital because, you can't tell the difference. No? So if you're acutely ill, don't get the vaccine at that time. Wait till you've recovered and you don't have fever, and then you can get the vaccine. Yeah, sorry, was there anything else?
Yes, ma'am, we have another question. Are there any risk of inactivated viruses getting activated?
No, no. They use, what is that? Some chemical, which I can't remember now. But that doesn't, yeah.
Okay, ma'am. We have another question. What's the scientific explanation behind getting the dose as a booster?
Sorry, could you repeat that? Sorry, can you repeat the question, please?
What is the scientific explanation behind?
Basically, you're trying to increase. So every time your immune system gets a booster, whether it is by a third dose or by exposure to the antigen naturally, by say you're exposed to someone who has the infection, your immune system, your memory cells get activated, proliferate, and your antibody levels go up, and your effector cell population goes up. Okay. So third dose means if your first dose antibody levels were here, then they start to drop, then you get a booster, so then it goes up, then after a little time they start to drop, then you get a booster, then it goes up. And the rise each booster dose is high, your antibody levels will be higher. The higher your antibody levels, higher you're against the variants, right? Because you will have a very powerful response as soon as the virus enters before it is even allowed to proliferate. So that's basically what we want. Before the virus can get in and proliferate and cause disease, we are getting rid of the virus. Yeah.
Okay, ma'am. We have another question. Is PCR or rapid antigen get positive even if the person is suffering from normal cold?
No. So I'm assuming you're asking if it's a normal cold caused by a coronavirus. If it's a normal cold caused by a rhinovirus or a paramyxovirus or some other, virus, then you have absolutely no problem. No, it's an entirely different virus, right? If it is a normal cold caused by one of these circulating coronaviruses, still no, because the PCR primers that we are using are specific to the SARS-CoV, right? So, I mean, the PCR that we do, and I think, I'm not sure about the PCR that, it's probably, the same thing, but the PCR that we are doing, say currently at the department for diagnosis, we use two primers. One is a beta coronavirus specific primer, and the other one is a SARS-CoV-2 specific primer. And we only give it positive if both are positive. If just the beta coronavirus is positive, we don't give it, right? We are only giving for both positive. The rapid antigen test is the same thing, right? The antigen is specific to the SARS-CoV-2. So just because you have a cold, even if it is one of the other coronaviruses, you won't get a false positive result. And these are high, the specificity is very good. The sensitivity of rat is not wonderful in low transmission settings. But now Sri Lanka is very high transmission setting, right? So the sensitivity and specificity of both these tests are actually very good, especially the PCR, gold standard. So with a normal cold, even with another coronavirus, you're not going to get a false positive. If you have a positive, that is fairly reliable. Yeah.
Ma'am, for how long do we have to depend on the vaccine for getting immunity against COVID-19?
You mean in the long run, like years?
Yes, the question is not much descriptive.
Right.
Seems to be he's asking that because that you told that earlier we have every time we are getting a dose, we are getting more and more immunity. So how long we have to depend on the vaccines to get that immunity against COVID-19?
Right. So it will depend on how long, it will really depend on how long vaccine immunity lasts, right? COVID-19, now we don't know for sure how long vaccine immunity lasts at the moment. What we have seen from real world data is that by about 6 months, that at least the two vaccines that have been studied, immunity seems to be dropping and efficacy seems to be dropping. Because of that, we might need regular booster doses. But, if at some point somebody develops a vaccine like the chickenpox vaccine, look, that's a live attenuated vaccine, right? Or the measles vaccine, live attenuated vaccine. You get practically lifelong immunity, right? From, 1 or 2 doses. So if somebody develops a vaccine like that, then of course, 1 shot and you'll probably be done. But the thing is the measles and the chickenpox viruses, DNA viruses, they don't mutate, right? There aren't really variants. Even with the vaccine, there are no variants. So for this virus, RNA virus that's, spreading fast, there's variants, the vaccines don't seem to be giving us long-lasting immunity, then dropping, we will have to keep vaccinating like the flu, because the flu vaccines have the same problem. One thing is they don't give very long-lasting immunity. And the other thing is that the flu variant or the flu serotype changes each season, each year, right? So in that sense, you can't have this one vaccine that gives you lifelong immunity, unlike chickenpox or measles. So then, for as long as that is our reality, we will probably have to keep having, you know, a new vaccine or another booster shot maybe every year. But if the vaccine technology improves, if people eventually Delta becomes endemic like dengue or flu, and most people are exposed and most people develop protective, because it's quite possible that our natural protective immunity, right? Especially the T-cell immunity, which hasn't really been studied very much because it's difficult to study. Antibodies are easy. You do ELISA, you can do antibodies. T-cell immunity, you need flow cytometry. It's difficult to do. And, you know, most people don't have the facility to do it, including us, which is a shame. But it's quite possible that natural immunity, especially if you get, you know, immunity lasts longer. So maybe in a year or two, by the time most of the world's population has been exposed to SARS-CoV or COVID-19, maybe all of us won't need vaccines. And maybe it is only the elderly or the people with comorbidities or the pregnant or, you know, people whose vaccine is reduced, the immunity is reducing, maybe only they will need vaccines. But it's hard to predict any of that now because we don't know how long natural immunity lasts. We don't know what kind of variants will occur. We don't know what future the vaccines hold. What we don't know at the moment, all we can really say is it is likely that eventually we will all need a booster if we want to maintain protective antibody levels. I mean, that's as much of an answer as I can give you at the moment.
Ma'am, we have one more question. What are the researches that are undergoing in Sri Lanka related to COVID-19?
Researchers, right?
Yeah, yes, ma'am.
So I mean, Jayawardenepura is doing a lot, right? They have massive, fabulous laboratory. So they are doing antibodies. They are doing neutralizing antibodies in healthy people and also in different cohorts. They are doing sequencing of the virus. They're looking at they are the ones who are finding the then we are trying to start, I mean, we are doing PCR, but we're trying to start sequencing in time. We've asked for a sequencer, and that donation will hopefully come through. And once they do, we can hopefully start. I'm doing antibody levels and seroconversion in renal dialysis and transplant patients, as well as in healthy people. I'm also, this is one of your graduates. She's doing this as an MPhil project. She's doing also antibodies in contacts, right? Because we don't know the seroprevalence. Like, so we don't know, I mean, we don't know how many people have actually been exposed and developed immunity. So we know who was PCR positive, and we know who was maybe antigen positive, but there will still be a lot more people in the population who have antibody, who had asymptomatic infection, who were never investigated. Maybe there are people who are PCR negative, but had very mild disease, and maybe they developed antibodies. So we don't know the bulk of the population or what percentage of the population that developed has antibodies, right? Especially in high transmission settings. So she's looking at that population. Other than that, I'm not sure. I haven't seen any publications from anywhere else other than Jayawardenepura. The biggest, I think, Jayawardenepura has several T-cell work, I'm not sure. Yeah, but that's the only publication I need. And like from a conversation I had with Professor Pires a while ago, there wasn't too much work going on. I think the problem is that most of the labs that are capable of doing this work, especially the clinicians, the virologists who are involved with this work, are very heavily involved in the clinical work, right? And that's, in a way, that's partly our problem as well. So we are doing clinical diagnostic PCRs all the time, right? Every day, every single day, we have to do PCR. It's very difficult to take the time out or even to find the funding. There's no funding. So to find the funding, equipment, people to do research is a bit difficult at the moment. And with the lockdowns, to get patients to come, to get students to come, it's difficult. So there are a lot of practical difficulties in doing research at the moment.
Thank you very much, madam. Hope you got answers, and I think we all got the benefit of this great opportunity today. So this is the high time to pay our heartiest gratitude to our guest speaker, Dr. Champa and Rantunga, and to each and every person who contributed to make this event a success. To get an update about upcoming events, you can join with the official Facebook page of our society. Our next session will be held on 6th of September in 2021, Monday at 6 to 8 p.m. So we'll wind up today's session. Hope to see you soon with another meeting. Till then, stay safe and good night all of you.